Erica, you there? Today is June 10th. Wow. Okay. Sharon, let's start business. When did we get to yesterday? Who remembers? We started with this. We did Hirschsprung. We did celiac, appendicitis. We went to renal, vesical urina. We did nephrotic syndrome. Did we do acute glomerulonephritis?
No, we stopped at nephrotic syndrome.
Nephrotics. Oh, yeah. So let's continue today with acute glomerulonephritis. Yes. So in children, it's mostly caused by a strep. Now, those strep guys, strep A, strep B, streptococcus infection. Okay. So your child will be having normal sore throat, winter season, strep infections. Yes. If you don't treat it, or if you treat and you don't comply with treatment, it can progress to cause issues for you, especially destroying the glomerulus. Okay, this is a bacterial infection, so they can just go and cause some issues. Okay, destroy the glomerulus and cause glomerulonephritis. Okay, so with glomerulonephritis, the beginning of it, you'll be seeing that the big molecules inside the blood. Okay, you'll be seeing why is red blood cell passing through the glomerulus to the urine. Okay, that's the inflammation state. As the wound heals and the scarring set in, that is where the reduced urinary output comes in. Okay, you can also see periorbital edema, hypertension. Yeah, so these are some of the issues we see. So a child who is 10 years, 12 years, okay, you'll be seeing all these hemodynamic instabilities. And once the kidneys are in trouble, your BUE creatinine is going to go up, okay, and the complements will go down. All those mechanisms to, store and also solve these issues will go down, the homeostatic mechanisms. Okay, so when you get a child like this, you monitor for the blood pressure, fluid balancing, then sodium restriction. Okay, diet wise. Okay, you put them on sodium restriction diet.
Hello, sir.
Yes.
Hello, sir. So
I'm
please,
listening.
the decrease complement, what is it?
That is what I'm saying. That those mechanisms uh, to help solve these issues, like the homeostatic mechanisms, is going to go down. Okay. So you see this bacteria is destroying somebody's glomerulus. You see your being creatinine going on. It does happen to us. We get infection always. The our being creatinine goes up every day, but you don't know sometimes when we are infected. But our body finds a way to solve it and clear the infection. But because this is a child, sometimes their ability to solve this problem, goes down. So you see their blood pressure shooting up, the edemas coming in, and all those stuffs. So with the nursing, do you understand, consultant? So with the
Yes, yes, please.
yes, so with the nursing, uh, nursing intervention, you monitor for their blood pressure. Sorry, I forgot to make my admins co-hosts. Okay. Okay. Yeah. So you monitor for blood pressure, fluid balancing, and what? In case of diet, you put them on sodium restriction diet. Okay. Yeah. Now let's look at hypospadia and epispadia. Mm. Every child, especially the male children, okay, we have like the penis like this, and this is the urethra. This urethra has a meatus. This is just the skin, but the urethra comes all the way to this side, and this is the opening of the urethra. Okay, we call it the urethra meatus. Yeah. So if this is the circle, if I want to magnify this side, okay, this is the meatus. It's supposed to be at the middle, at the center, not at the top. This hole should not be at the top, and this hole should not be below. Okay. So if this is the center, anything at the top is called epi. Okay. The hole at the top is called epi, and the hole below is the hypo. That's it. It's English. You don't have to worry yourself. So this is a congenital urethral opening abnormalities. That is why the midwives will be assessing all those stuffs, especially. So opening on ventral or underside of the penis, then epi, just like the top of the penis. Okay. Do not circumcise these children until they surgically repair. They will close this hole. Okay. Redirect this urethra to the center and create an artificial hole to connect to this so that any urine coming from the bladder will pass through. If this is the bladder, it will pass through the center, not the top. Yes. So until we correct this abnormality, don't take the child to any wanzam, any guy to or all these Jews to circumcise or the urologist to circumcise the baby for you. Okay. So that's another issue. Now let's move to endocrine system of pediatrics, the endocrine system. Okay. So the first condition we're going to look at is what? Diabetes mellitus. We know endocrine to be a system where hormones are released into the blood without passing through any duct. Without passing through. So if this is the bloodstream, I have a structure here. It has a hormone. Okay. Ideally, hormone is fluid, liquid. Okay. Yes, if liquid should be tunneled or channeled to pass through a hole or a tube into the bloodstream. But endocrine system does not do that. Okay. Yes, they release directly. They will just when Jesus was on the cross, they gave him what? They gave him, he said he was thirsty. Okay. They gave him what? A drink to take. They put it in his mouth straight and it went to his body. They did not put a straw inside that juice for him to take. So if this was a straw, if they had put a straw here, it would have been exocrine. But because there was no straw, it became endocrine. Okay. Yes. So that juice Jesus took, those of you who are Christians, it had a serious effect on his what? Catecholamines, the adrenaline and the noradrenaline. So it caused systemic vasoconstriction, severe one, that his capillaries supplying the skin went under severe stress. And go and learn it. Anytime your capillaries supplying the skin undergoes severe stress, it bursts. So when it bursts, it will mix with what? Sweat. And you see the plasma and the sweat mixing together. When it comes out of the body, the sweat is very thick and heavy, like clot of blood. That is what happened to Jesus. So back to endocrine. Yes, there are structures in the body that releases juice straight into the hot bloodstream without passing through any channels. One of them is the pancreas. Okay. For some reason, whether it was genetic makeup, whether it was cell mutilations, whatever, children are born. These children are born where they have issues with the beta part of the pancreas. Okay. So pancreas is divided into two. We have the alpha and the beta. Okay. We know the beta, these cells here, are cells. So yesterday somebody said that the basic unit of life is cell. And we have cells here. Yes. So when you take the pancreas and you look at the cells, they are not the same. We have some cells that is in different shape or form. We call them beta cells. And we have the alpha cells. Okay. This beta produces insulin. And the alpha, this part, produces glucagon. These two guys are brothers, twins, so from the same mother. Okay. But they are never, they never agree. Okay. They never agree. They are two brothers, twins, but they never agree. So what does insulin do? When insulin gets to the bloodstream, insulin will come and act on the glucose here. Okay. And in between these blood vessels and the cells, okay, there is a key. This key is called what? Insulin channels. Okay. Yes, insulin channels. So when insulin come and bind with this key, they will open the door for hot glucose to move to the cells. At the same time, they open when insulin channels are opened. The sodium and the potassium channels are also open. And you see that potassium will be moving out to the cells. And sodium will come to the blood. That is it. So anytime insulin is pushing glucose to the cells, potassium is also following it. Okay. So those of you who manage DKA, diabetic ketoacidosis, which is a complication of type 1 diabetes, okay, you can't give insulin without knowing your potassium level. Yes. So that is what you should know. Okay. So insulin will come and do this physiology and go. Insulin will be pushing. They will push the glucose to. When we have enough glucose in the system, we have enough sugar in the system. Okay. The glucagon too will come in. They will come and do the opposite. Okay. They will come and do the opposite. They will rather cause what? More this thing. They will come and cause glycolysis. Okay. Yes. They will come and cause glycolysis. Okay. So that there will be a balance always in the system. That is what happens. But this child was born with what? A damage to the beta part of the pancreas. Damage to the beta part of the pancreas. Okay. So anytime glucose is in the blood, there is no insulin or little insulin will be produced. Yes, that little or small amount of insulin coming to the blood cannot push all the glucose to the cells. So always you see them having hyperglycemia. Okay, hyperglycemia. So what do we have to do? We need to give them artificial insulin. Insulin that when somebody dies, we can take the person's pancreas. Okay, take this part, beta part, take it to the lab and synthesize, regenerate artificial insulin. Or sometimes we can take animals, their insulin, like the pig and all those animals, to produce insulin and give us what? Artificial insulin. Yes, to help solve these guys. So we say they are insulin dependent. Diabetes mellitus. Insulin dependent diabetes. So they have absolute insulin deficiency. And it is childhood onset or adolescent onset. They have so many signs and symptoms, but these three guys will be running through them. Polyphagia, polydipsia, and polyuria. Okay. Polyphagia, plenty glucose in the blood causes what? Diuresis. That's it. Diuresis. Plenty glucose in the blood. Not plenty glucose in the cells. Take note. I'm talking about two environments. Okay. And let's focus on the blood vessels. So hyperglycemia, when glucose is plenty here, it will cause automatic what? Diuresis. So this patient will be peeing. What is he peeing? He is peeing out plasma. This plasma is supposed to nourish the body. Okay. It's supposed to nourish the cells. It's supposed to, because it's a cyclical. Okay. Yes. When the lymphatic vessels bring the lymph to these blood vessels will carry it to the kidneys to filter all the dirt and come out as urine. And the clean blood will go back. So some of the plasma will cross again to go and nourish the cells, the interstitial spaces, and also that is what is a cycle. It's a cycle like this. But when the plasma came to the bloodstream, there was hyperglycemia. So the kidneys were drained all the plasma out. Do we think we will have enough plasma to circulate again? No. So there's going to be a compensatory mechanism because of maintaining blood pressure. The blood vessels will say that, okay, the little volume of plasma left in the blood, I am not going to let it cross to the cells. I'll keep it so that my blood pressure will be stabilized. Okay. Keeping it means you are starving yourselves. Starving yourselves means patient will be having what? Polydipsia, the urge to drink water. Okay. The urge to drink water. Yes. So you see that somebody's mucous membranes will be dry, the mouth, the lips, everything will be dry. Yeah. Okay. Another thing is when the glucose is high here, and because we are not getting insulin to push them to the cells, we need glucose in the cells to produce what? Who knows? Ellen?
Energy.
That's
ATP.
to produce what? I hear you.
Energy. ATP.
Energy. Okay. Don't say energy. Be a science student for me, okay? Sorry, I'm just pulling your
ATP.
legs. ATP, adenosine triphosphate. Okay, every food you eat, this is the end of it. That banku you eat, I can eat banku. You can eat fufu. Somebody can eat jollof. Other person can drink cocoa porridge. No matter what you eat, this is what you get. ATP. Whether you eat plenty or you eat small, or you even starve yourself. If you starve yourself, the cells will say, okay, no problem. We have fat, body fat. Let me go and convert the fat to glucose. Because, yes, we call it gluconeogenesis. Okay. Yeah. So, ATP. No. The insulin to push the glucose here to this medium is not there. The cells need what? Energy and all those stuffs to produce ATP. They are not getting. So the cells will go, the sensory nerves will go to your brain. And the brain will send what? Impulses back to your GI system, gastrointestinal system. Okay. This gastrointestinal system, one day I'll tell you, there is a certain hormone inside the stomach. That hormone, forgotten name. Yeah, it's two types of hormone. I'll get the name because I'm creating a video on it, a short video. We have two types of hormones inside the stomach. One is for hunger, and one is for satisfaction. Okay, one is for hunger, one is for satisfaction. Somebody can Google it and tell us the name. I've forgotten it has some Greek names. Two hormones in your stomach. So the question is, Why do people eat a lot? Every day they are eating, but they are always hungry. And why is it that somebody does not eat? We have some human beings, the whole day, they will not eat, but they will not feel hungry. It is these two guys. I have a short video. By Friday, it should be out on this. Okay. Yeah. So when you listen to that video, you understand why sometimes you have eaten, you just ate, but you are still hungry again. Yeah. So that is it. So cells are not getting glucose. So they will be starving. Okay. So the hormone for we call them the hunger hormone is called ghrelin. Get me the satisfaction hormone. There are two types of hormone in the stomach. One controls hunger, and one will tell you that hey, you have eaten, it's okay, stop eating. Satisfaction. The more you eat, the more you eat, the more you damage the satisfaction hormone. You make it insensitive. So your brain cannot coordinate with the satisfaction hormone to tell you that you have eaten, so stop eating. Okay. So all this weight loss medication, GLP, Monjaro, all these injections, they work on these two guys. Okay. And when you inject it, one, it can suppress it, especially the hunger hormone. It can suppress it for a whole 1 week. Okay, a whole 1 week, you will not feel that you are hungry. Yes. So yes, leptin. Okay. So what I'm do. Let's continue. So cells are not getting glucose. They will be hungry. When they are hungry, they will what? They will tell the body that hey, eat, 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 eat. They will stimulate the hunger hormone. So patient will be eating polyphagia. Okay, polyphagia. There is fatigue and weight loss. So management, you give your insulin boluses. You know, we have done insulin. To those of you who doesn't have that slide, I think Ayariga will put it on the page sometime to come. So we've done insulin, all the insulin types, what you are supposed to do. Type 1 diabetes. Okay, when we were doing adult physiology. Then your carb counting, your carbohydrate counting. So you check it. Then your glucose monitoring. So when you are dealing with type 1 diabetics, you monitor what they are taking in. That is one. Two, what they took in. How was it able to be converted to sugar? Okay, to increase the glucose level. So that is two. Okay, so these two things is very important. The 6-day rules. Yes, who remembers it? This one, we have been saying it over and over and over and over and over here. 6-day rules for diabetics, type 1 diabetes. What goes into it? Consultant, do you remember?
No, sir.
Never omit insulin. 6-day rules. They say that the rule says never omit insulin on 6-day rules. That is rule number 1, and that is the only rule though. So what goes on with 6-day? We say that type 1 diabetic is having 6-day. What are some of the signs and symptoms? Yes, who knows? Because if you don't know this, You go and omit somebody's insulin, and they will seize your pin. Yes. I remember when I was in UK, one nurse was sacked in our unit because she went to check somebody's blood sugar. It's a night nurse. Went to check somebody's blood sugar. And the blood sugar was in the fours, like 3 or 4 zones here. 3 zones, in between 3 to 4. One of them, I've forgotten the figure. But this patient was due for Lantus. Do you know Lantus? The long-acting insulin. Okay. And the nurse omitted it. She did not keep quiet. Too. In the morning, she went and handed over. In the night, the blood sugar was this, and I omitted the insulin. Okay. She went home and they called her. The nurse who took up from her in the morning went and reported that the previous nurse has caused omission. Okay. And it was a deliberate act. Because you sold yourself. Okay. So they called her, started investigation. It came out that yes, and when they call you, they will be smiling with you, laughing with you. They will take your mind from the what you have done. So once you confirm that yes, you omitted it, trouble has come. Okay. Because long-acting insulin does not cause hypoglycemia. Okay. So never omit. Yes, who has seen the sick day rules? Papa Tell it.
Yes. Well, I
Yes.
just spotted some, but I'm not so sure exactly. Yeah. So with regards to insulin adjustment, they say you should never skip it. You should never
Yes.
skip it. And you should try to also contact your team when in doubt.
Okay.
And about the
What else?
monitoring of the glucose, you will have to monitor it regularly, like 2 to 4 hours. Blood glucose can what do you call it, rapidly be reduced or drop down if you are not monitoring it. You also check your ketones, especially with DM type 1. You check ketones too, and you record everything that you monitor.
Okay, so let me ask
You
you
try
this
as much
question.
as yes.
You are managing type 1 diabetic. You check the blood sugar. It was, let me see. Let me use the grams. It's a long time I did the millimos. It was 157. And the protocol, the sliding scale says that 157, you give 1 unit of what? This Lispro, the short acting. Okay, the Lispro. Okay. You didn't give because it was 157. Somebody should divide this for us. 157 divided by 18. You get
That
the
is
millimole.
about
Somebody
8.7 millimoles.
Okay, so 8 point, let's assume it is 8.7. If it is 8.7, and you are supposed to give this, but maybe you were busy. You didn't give, but you still remember that you were supposed to give. Okay. When you check the insulin, the glucose, it was 8 o'clock a.m. Now, the time is 11 o'clock a.m. Will you still give the 1 unit or not? If yes, explain. If no, explain. You take insulin at 8 o'clock a.m., 157 or 8.7. The sliding scale says give 1 unit of insulin, Lispro. You were busy, so you didn't give. It's now 11 a.m. Will you give it or not? 2 hours difference.
Okay, so let me try.
Try.
But but at 11 a.m., I'm very, very sure that I will not get the same figure. Now I have to check and know the figure at that time. Whether it is. Yes.
You will check to know the new figure. Why will you check again? Aside your explanation, what does the protocol say? When you take insulin now, at how many hours interval? You take insulin now. You were supposed to intervene. You didn't intervene because you were busy. Now you are ready to intervene. You check the time you give you check the time you did the first check, and you look at the time you want to intervene. At how many time intervals do you have to check again? Yes, who knows? To continue. You have the first answer, you are right. But I want you to know that. How many?
What I know, 4 hours different that you have to.
Then if 4 hours, 8 to 11 is 2 hours. We shouldn't have checked again.
No, the probability is that say, it might go up or because if it is at 11 a.m., it might either rise or depending on the status of the client. The recheck-in is the that we usually do.
Okay.
Yes.
So yeah.
Because
that is why I gave you.
Yes, because maybe you were supposed to check in that 4 hours interval. You're supposed to give at 1 unit, and then you have waited additional 2 hours. It's now 6 hours. It's now 6 hours. Okay. Meaning that you have to check again to know the new figure, man, before you intervene.
But I'm hungry.
Okay. Yeah, Grace, are you talking or you are conversing with someone? Any other point? Victor is right. Somebody should add it. Okay. Right. So, Papa, let's go. 1 hour interval. Once 1 hour, the time elapsed 1 hour. You are dealing with type 1. Check it. Me, if I'm working, even if you are type 2, I'll still check. Because the time you gave the insulin will record on the system. And the time you checked. Nowadays, the glucometers, those of you who work in advanced hospitals, that glucometer, it is linked to the patient's file. So when you scan the patient and you check the glucose, you don't have to go and write it in the patient's note. It is already there. By the time you leave the patient's room to your computer, that glucose reading is already on the mar chart. Okay. So they will know when you checked and when you give the medication. If the time is more than 1 hour, why didn't you do a second check? Or you gave insulin? Okay. So that is it. That is it. Okay. Let me ask you this question. You are still dealing with type 1 diabetic. Okay. Or yes, type 1 diabetic. But this type 1 diabetic, he is that type that he doesn't mostly get insulin fluctuations. Okay. So you came for night shift. You were supposed to give Lantus. That's the long acting. Okay. And this thing said, let's say 14 units of Lantus. Instead of going to give Lantus, you went and gave Lispro, rapid acting, 14 units. After you gave it, then you remember that I've made a medication error. I made error. Okay. What will you do? Yes, Victor. You have given somebody rapid acting 14 units. What will you do? Instead of Lantus 14 units. What will you do?
Please. I was far from the device. The smoker was cranking. This was the question got back.
Managing a diabetic, you are supposed to give long acting 14 units to run for the night. You went for night shift. When you went to the fridge, instead of taking Lantus, you mistakenly took Lispro, that is rapid acting, and gave 14 units of rapid acting insulin. What will you do as a nurse? If you have committed, Dave.
Okay, Dave.
You report your superior for a medical error.
Okay, sir, for me, I will give 50% to counter it, and then I report to my superior, because if you wait and wait, the person might go into hypoglycemia, which is dangerous, and eventually cause death. That is my own.
You give instantly, okay, but you need an order to report. Then the doctors will prescribe 50% dextrose. Okay, 50 in 50 mils. Mostly this one will come 50 mils. 50%, 50 mils. Don't forget. Okay. Or you can give 25, but this one is too high. 14 units. Okay. Secondly, if the patient can tolerate orals, like you and I, what will you give? Victor?
So I would have given half of orange. Oh, sorry.
Okay. Yes, Victor.
I read the cover. They said, like, give anything sweet, orange juice, or sometimes, if anything like Coca-Cola or sugar solution.
Sugary solutions. Okay, perfect.
Can you apply the 15 by 15 rules here? 15 grams, since there's, or because you have not checked the sugar again to know the value. I would say you should give 15 and to recheck in 15 minutes time.
Yeah. So 50-50. Okay, you do that. So instantly, patient has not shown any sign of hypoglycemia, but you should start hypoglycemia management instantly. Okay, so let us know all these things. We are human. We make mistakes, but you should know how to go about it. Then you document in the incidents report. Can we say this is a near miss? A near miss.
Yes, because the harm has not been committed. Yeah.
So it's a near miss. Okay, consultant, your hand is up.
Yes, sir. Sir, please, when do we use the 15-15 rule, and when do we also use the 50-50 rule?
Oh, I was saying the 50% dextrose. The syringe comes in. Have you seen the syringe before? The 50% syringe. The 50 mils syringe.
Yes, please.
So mostly nowadays it's preferred, like the pharmaceutical companies, the 50%, they make it into a big syringe, 50 mils. So you just take the box. When you take one box, 50% like this. So unlike those days that you go and take a bag, insulin bag, no, now most of it's just a syringe. So you just screw, like have you seen the adrenaline syringe before, like when we are doing cardiac arrest? Okay, it comes like that. So 50% dextrose syringe. So that is how it looks like. This. So I mean, this is what we use. Me, the hospitals I work here. This is what. So if you cause any, so the syringe is here, the drug is here, and this is your plunger, and there's another cover here. So just remove the cover here, put the plunger in, then you push. Okay, you can give 25 mils, or you can give, depending on how severe the severity of and how fast you want things to be solved. Okay, yeah.
Sir, please, I think my question is not yet answered. My question is the 50-50 rule and then the 15-50 rule. Is it applicable in children?
Yes. You can't give 50%, 50 mils to a child. That's too much now. Okay. You can give, like, say, you can give like 5 or 10 mils.
Because
15 minutes time, you check your glucose. Titrate to effect and put the patient on a monitor. That's it. You understand? If you
yes,
go and
sir.
give 50 mils to a child who is 4 years old, because severe hyperglycemia. Okay. So it's
So
not,
how about
it's not rigid.
It's not rigid. Okay.
It's not, it's nursing care is not robotic. It's not rigid. Okay. That is why I say it's only anatomy that is rigid, but physiology is flexible. So you apply the physiology, the presentations, and the interventions. That's it. So you have the whole 50% syringe holding you. Somebody will say that I want to give all, I'll give all at a go. Somebody will say that, oh, let me give 25, half first, then check, then come back and 15 minutes time, I check the glucose again. I give the rest. 15 minutes time, when you check the glucose and it's up. Okay, example, you check somebody's blood glucose and it was 1.8 millimoles. You have 50% syringe holding you. Okay, dextrose. You give, let's say you give 25. Then you waited for the next 50. Don't wait for 1 hour. The patient's brain will shut down. Okay, 15 minutes. Okay, check the glucose again. When you check the glucose has come to 5.2. Will you give the rest of the 25 mils? Depends on you. Okay. So that is what you should know. So it's physiology. You learn, you apply. You check, you apply. So a country like United States, they work with lab results, investigation results, scan results. If they don't see, they don't act. You can't come to the hospital that you are having headache or you are having back pain or abdominal pain. We did CT scan, we did not see anything. There is nothing in the blood. There is nothing in all the investigations. Negative, 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 negative. Then you expect them to give you first class medications. It won't work. They won't give you. When you go to UK, you go and tell them that you have sore throat, and they do investigations and they see negative for strep or negative for any of this flu. They will not give you any medication. Forget. They will tell you that go home and take paracetamol. So that is how it is. So don't abuse drugs. Let's move on. This is what I like. Their major problem with type 1 diabetes is diabetic ketoacidosis. Take note of that. Diabetic ketoacidosis. Diabetic ketoacidosis. You, type 1 diabetic, you don't have insulin production. Okay, insulin is not coming. Pancreas is in trouble. Your bloodstream is full of what? Sugar. The bloodstream is, and your cells are always starving with what? Sugar. Less sugar. Okay. So the cell itself, sometimes with the little insulin you inject, it will push a little glucose to the cells. But that won't be enough for the cells. So the cells will sometimes rely on the surrounding fat. Yes, it will go to the fat stores. So it can go to your stomach, it can go to your buttocks, where fat is stored in the body. Okay, go and take some. Take it to the liver. The liver will change the fat. We call it lipolysis, breakdown of fat to glucose. Lipolysis. They will break it down, then they change it to glucose. And glucose will come here and it will be used to produce ATP. Okay. Perfect. So when there is no sugar, no insulin, and glucose is not going here, the cells will solely 100% depend on the fat and break it down to get its glucose to produce ATP. But the cells will not say, I want to die because blood is not giving me sugar. No. They will do something to help themselves. Okay. This fat breaking down, the cell is very selfish. Okay. They have broken down fat. When you break down fat, you get what we call ketones. That's what? Glucose. Okay. So let's do chemistry. I love chemistry. This is the formula. Apply heat. This fat will go to the liver. The liver will apply heat and liver enzymes. Okay, so heat production is very important. Metabolism, heat. That's why your temperature should always be between 36.2 to 37.2. so that the liver can work well for metabolism. Simple. So imagine I have taken one fat and broken it down. I get ketones plus glucose. So the cell will take the glucose to itself to produce ATP. What happens to the ketones? When the body wants to excrete any waste product, where does it go to? Who knows? The body wants to excrete the cell, the byproduct or the waste product of the
It goes
cells.
to the kidneys.
Where will it get to first before it goes to the kidneys?
The liver.
Liver.
Yes.
Bloodstream.
It will go to the liver. One. This one. It will go to the liver. And the liver will do something. It will convert these ketones into water soluble. English. Water soluble format. In science, we call it hydrolysis. Have you heard it before? Hydrolysis. They will break the substance, the molecule down so that it can be absorbed and dissolved in water. That's it. Because anything watery goes to the kidney. So they will hydrolyze it, bring it back to the blood, and the blood will take it to the kidneys. And the kidneys will what? Excrete it for us to see it as urine. Okay. But the problem is coming from where? The cells. So cell has taken the glucose, thrown the ketones away. Cell has taken the glucose, thrown. And because the cell is seriously hungry and they need more glucose, what do? They take the fat and produce a fat. See, let me tell you something. If you want to lose weight, starve yourself. When you starve yourself for a week, people who don't eat, anorexia nervosa and all those stuffs, have you realized that within a week or two, you quickly lose weight? Have you realized that? All these people who are taking injections that they don't want to become fat, within a week or two, they will quickly. Why? Because your metabolic rate increases. So more fat is broken down at a very fast rate. Unlike you have eaten glucose, carbohydrate, and carbohydrate is doing. So somebody can choose that I don't want to eat carbohydrate again. All my food will be proteins and fats. Protein and fat. Somebody will be eating egg like 2-3 in the morning. Proteins and fat. You will lose weight quick because protein does not have store. So it's only fat. And the fat too will be broken down. But the dangerous aspect is that when the cells break down fat and they take the glucose, where do they throw the ketones away? This is a waste product, baller. That's been rubbish. The body does not need this rubbish. They will throw it away in the bloodstream. So you will be seeing ketones, 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 ketones. Remember, before there is glucose here. Okay, the cell has used glucose. It will bring some again to the bloodstream. So more glucose add up. More glucose add up. Waste products too is coming. More ketones add up. More ketones add up. More ketones add up. More ketones add up. Okay. The blood is circulating. it has gotten to the kidneys, ketones will be released out. So when you take the urine sample, you will see ketones. Or this patient has kidney failure or something has happened, or we don't even want to use urine to check for ketones. We can still take your blood because the ketones are coming from the blood. Anything you see in the urine came from the blood. So if the patient says, I can't urinate, or I don't feel like urinating, that doesn't mean you can't pass an IV line and take blood sample. You are a nurse, you want to check somebody. Let's say the policeman brought a criminal to your department that we want to check for drugs. If the patient is taking drugs, this prisoners, they will tell you, they know physiology, because once they detect that you take drugs, you are gone, you are finished. They will destroy your file. Okay. So the prisoners will tell you that I don't feel like urinating. What can you do? I don't feel like urinating. Okay, no problem. But you have a vein. I can take your blood and to check for mine. Yes. So ketone will be building, glucose will be building. Ketone will be building, glucose will be building. Okay. It will get to a level. The ketone will get to a level. Remember, ketone is a positive ion and it behaves like an acid. That is the word. Behave. Like an acid. But what does the saying says? The saying says that when it looks like a duck and it thinks like a duck, it is a duck. So when ketone is behaving like an acid, it is an acid. So your body is building up, or your bloodstream, there is a buildup of ketones, which is behaving as an acid. So when you check your blood, the pH will change. The pH will drop and shift to the acid level. This pH shifting, do you know why animals are, some people will say animals are stronger than human beings? Because a car will knock an animal down. The animal will sleep, then when they get up and be walking. But a car will knock the same human being down. This human being will die. Why? Because when you hijack the human body, or when you injure, or you cause trauma, or you cause distress to the cells, potassium moves. Okay, potassium moves. So it causes issues to the human being. Ketone moving to the cell, to the bloodstream, will shift the pH. And a human being, every human being, those who are born today, those whose mothers are giving birth to them today, and they are able to survive with a pH scale of what? 7.35 to 7.45. Let me move the scale to below or above. The patient will be unconscious, or they'll be lethargic. It can happen to me, it can happen to you. If your pH shifts, this is a very narrow scale. Let's do the mathematics. 7.35, no, 7.45 minus 7.35 is 1.0. Okay. 1 point or 0.1, which is which, Nico? 7.35 to 7.45. What is the
0.1?
0.1 scale. So every human being, your pastor, the president of your country, whoever, we are surviving with this pH. If it becomes 0.2, you lose consciousness. We have to intubate you, or we have to give you IV fluids to dilute whatever is going on in your blood. Okay, so that is when we say somebody is acidotic or alkalotic, it means this 0.1, either some numbers have been added to it, or some numbers have been subtracted from it. Is it? Okay. Some numbers have been added on. So we are all surviving with this narrow, it's very narrow. It's even narrower. It's even narrower than this Vanco and all these medications. We are surviving, you and I. Me, I'm here. I'm talking because of my pH is within this range. Okay, yes. So this ketones building will cause what we call metabolic acidosis. Some of them will come to the lungs. Okay. Your lung will detect it. They will send information to your brain. The brain will say that, okay, let us what? Because the pH has slowed you down. You are building CO2, you are building all those stuffs. So the body will try to what? Breathe fast. The lungs will breathe fast. Why? Because the more you build CO2 will tell your respiratory center that breathe. So you will breathe fast. When you are breathing fast, somebody who is standing beside you, that carbon dioxide you are breathing out is mixed with what? Ketones. And the ketones smell like a fruit. Okay. When you cut apple, pineapple, orange, you see that smell. You see that smell. Yes. It smells like that. Okay. That is it. So the patient will be having what we call Kushma respirations. Have fast breathing. Okay. And fruity breath. The pancreas is in the stomach. You'll be having abdominal pain. It can be that your pancreas is diseased. Your pancreas has a tumor. Your pancreas is suppressed. Whatever is happening, patient will be complaining of abdominal pain. Okay. Some patients vomit to compensate or dehydration. That's it. So how do we diagnose it? The blood glucose is up, which you know. pH is going down. Your bicarbonate will try to compensate. So they will either go down or go up or remain the same. I mean, they are there to help you. Ketones should go up and potassium will also go up because there's trouble in the cell. There is distress in the cell, so potassium will move. Okay, yeah. So management, your IV fluids to dilute the blood, okay, reduce all the ketones down, then insulin infusion. But before that, your potassium should be checked. You can't go and give insulin to a patient that you don't know the potassium level. Okay. If you check the potassium level in the blood and it is 2.0, will you still give insulin? Victor?
No, sir.
No, so what will you do?
Sir,
Mm-hmm.
I think you may have to wait for others to for potassium to give KCL before to correct the KCL before you start giving the insulin, correcting the hyperglycemia. Or we can start the fluid resuscitation. The fluid can also help.
Don't bring fluid. I'm gonna kill you. This is the IV. This is the vein. Okay, let me draw. This is the vein. Our bloodstream. Potassium is 2.0. Potassium is a crystal. They are marbles, stones. Okay, crystal. If I pour water on stone, do we get more stone? No. You are only diluting it. Okay. Potassium, sodium, they are all crystals like salt. So when you pour water to it, you rather dilute it. That's why we have dilutional. You hear people diagnose it dilutional hyponatremia, dilutional whatever. When you take water from the bloodstream, you are rather making the crystals concentrated. So somebody is losing fluid, then the potassium will be up. Because when we do specific gravity, you see that there are more crystals in the blood than the water. Nicholas, do you understand? Good. So
Yes, sir.
I have plenty sugar here. I have plenty sugar. Let's say 300 or 400. I have ketones, plenty here. Okay. I can give water to dilute these ketones and reduce the acidosis. Okay. At the same time, I can give water to dilute this sugar. That is why they say give your normal saline. Why? Because this has sodium. So the sugar and the salt to dilute it. And normal saline too will hold the sodium, the water will hold more water to itself. Okay. So that is it. So the first intervention is the dehydration. You are trying to correct it and also to dilute, make things simple. But this potassium, they are stones, crystals. Nothing will happen. You are just disseminating the potassium, the same 2.0. So if I want more potassium, I will add more potassium before I give my insulin. So the insulin is coming to push some of the potassium to the cells and also the sugar to the cells. That is it. You keep doing this till the sugar level drops below 200. When it drops below 200, you change the diabetes regimen to sliding scale. Okay. So
Whatever,
you
anything is fine.
realize
It's in my bag. The G100, I don't remember I took it.
okay, you change it to the sliding scale. Okay. You can't keep giving insulin drip with a glucose of less than 200. You are going to cause hypoglycemia. Okay. You are going to cause hypoglycemia. So stop and rather give what? Dextrose 5-NS. 5-NS. Okay. Why? I have pushed sugar out of the blood. Remember, some of the 9%, 0.9% sodium chloride is still here. The insulin you give to is still here. So the physiology is still ongoing, though you have stopped the IV fluid and all the drips, but you did not remove the insulin from the blood. So the physiology is still there. The remaining insulin is still pushing. Okay. So like we said, you give the dextrose to hold, to maintain the sugar, the normal sugar in the blood. And the normal saline part too is giving what? I mean, it's causing the hydration stabilizing things for you. Okay. Then you switch to the sliding scale. So the sliding scale, every hospital has their protocol. If you check your insulin and it is above 140, give what? 1 unit of rapid acting Lispro. If it is below 140, 70 to 140, don't give insulin Lispro. Don't give anything. Okay. If it is below 70, hypoglycemia, give 50% dextrose. Simple. And it goes like that. So you'll be doing that. Okay. But remember, we had ketones plenty in the blood. That shifted the pH. If this is the pH scale. And here was 7.35 to 7.45. Remember, the ketones, which was an acid, moved our pH from here to here. Maybe 7.20, which so many human beings cannot survive with this pH without immediate medical intervention. Okay. But because of example's sake, let me put it here. This is a serious high acid. Your blood has become so acidic. Okay. Now, my acid is here. The acid was supposed to be here, and the base is supposed to be here. If I take a tape measure to measure from the acid to the base, maybe I got what, 10 centimeters. I am making it more practical so that you understand how to manage diabetic ketoacidosis. All this physiology we have done here, interventions, that is not the aim of managing diabetic ketoacidosis. What I'm telling you now is the treatment goal. So open your eyes. If you don't understand, tell me. I'll go over it. Okay. So before the pH moved down, when you take a tape measure to measure, it was 10 centimeters because you are a tailor. Now the pH moved from here to here, and it's 7.20. So the distance has now moved from here to here. So when you bring your tape measure again, you are going to measure from here to here. And that can give you like 20 centimeters. Example. Okay. So what happens? We have something we call anion gap. You and I, our anion gap is closed because we don't have any diabetic ketoacidosis going on now. So our anion gap is 10 centimeters. Okay. I'm using that example. But when you get your diabetic ketoacidosis, now anion gap has become what? 20 centimeters. Will you allow this human being to be working with this measurement? No, they will die. So what do you do? The aim is to bring the anion gap back to normal, at 10 centimeters. Until you bring it to normal, you are not done with DKA management. That is the treatment goal. So all these IV fluids you are giving, because there's plenty acid in the blood. Let me give sodium chloride to dilute it. Let me give my insulin. Potassium, is it low? Let me replace it. Let me give insulin to push the blood sugars and the potassium out. So all this, let me change to sliding scale. But my anion gap measurement, the phlebotomist, or if you don't have any phlebotomist, you take your blood sample to the lab, go and check. I'm treating diabetic ketoacidosis. What is my anion gap? 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 A lot of people rush. There are some people when we bring a patient and the patient is delirious or patient is lethargic. Okay, type 1 diabetes, so lethargic. Patient is having rapid respirations. Okay, patient is rapid respiration. Let's say respiration rate is above 30 count per minute, CPM. Okay, it is physiology. That rapid respiration, that Kushma respiration, it is a compensatory mechanism to blow out CO2 out of the body. But there are some hospitals, they quickly rush to intubate this patient. When you intubate a patient, you have given the patient sedative and you have given the patient neuromuscular blockage. You have blocked the muscles. This patient having diabetic ketoacidosis need the respiratory muscles to breathe. But you have gone to block it because you want to intubate. It is not every patient that comes to your hospital with unconsciousness who is also having Kushma respiration that you need to intubate. It is not your priority. So NCLEX will bring all these answer options. If you choose intubation, they might fail you. It should not be your first step. Diabetic ketoacidosis, when you see this respiration, that's why I've highlighted it, this one. Kushma. It is rapid respiration. Remember, the patient has built a lot of acid, so their system has slowed down. Okay, and they are building a lot of CO2. What helps us to breathe? It is CO2. It is not oxygen that helps us to breathe. Too. Oxygen is a fuel. Oxygen is a fuel for the cells to use to burn glucose so that ATP will be what? Produced. That is it. Oxygen, 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 oxygen. That is the function of oxygen. Okay. Oxygen. That is it. But you need CO2. What will tell your lungs to breathe is CO2. CO2 will go to the brain. So when somebody is building CO2, let's say I take a knife and I choke you, or somebody has tension pneumothorax, they can't breathe. The CO2 will build up, go to the brain and tell them. So you see rapid respiration, but the volume and the rhythm will be reduced. That is it. Okay, that's it. So this one is a compensatory mechanism. So don't go and intubate. You see some health care workers, they will now go and take ambu back. Okay. Yes. So your anion gap is your priority. That's it. I'm done. So let's move on. Every day we will take something serious and open eyes with it. Another issue we have for children is hypothyroidism. Okay. Mostly it's congenital or acquired. So you see babies or children under 18 who have low thyroid hormone production. So their basal metabolic rate will slow down. Will slow down. Okay. Will slow down. That's it. This thyroid hormones, this hormone, what does it do? It is being produced by the thyroid gland. The thyroid gland is like this. And the hormones are here. Okay. Then we have the parathyroid guys sitting at the back there. Okay. Also working with the calcium guys. Okay. So this thyroid hormone is a liquid. I've told you, it's a fuel like water that you drink. The body has cells whose function is to metabolize the liver and the kidneys and the lungs. Okay. Yes. So this liquid will go to the blood, and the blood will carry them to these guys. Okay. And they will help, especially the liver, and they will help it to what? To speed up what? They will speed up metabolism. Pick a analogy, example to our human life. Your mother has that old African pot like this. Okay. Then they will put firewood there. 1, 2, 3. Okay. Then the cooking pot is here. Champion. And the fire is blazing. The fire is blazing. Okay. This firewood is your thyroid hormone. The cooking pot are the liver, the kidneys, and all those stuff. Okay. Because you need to put the firewood inside it. Somebody will ask, where is oxygen? Imagine you take one of this firewood out. Are you going to get plenty fire? No. So how do we get plenty fire? Your mother will tell you, go and take the fan and be blowing air. So the fan is your oxygen. The fan is your oxygen. You blow air. So air, the oxygen helps with combustion. Without this firewood, can you just go and blow fan under the stones for you to get fire? No. The same thing happens here. I have plenty firewood. I will get plenty fire with little fanning. That is the thyroid hormone. Okay, that's the thyroid hormone. If I have small or only one stick here, only one stick, as in hypothyroidism, one stick here. Yes, I'll get fire, but I'll need to put in more fanning because the thyroid hormone is only one. And this food, it will take a long time to cook. That's it. Okay. So what happens? Let's come back to physiology. Wall growth. This cell is waiting to get energy. ATP. The ATP is your ampesi, your fufu, your rice in that bowl. Okay. If the thyroid hormone is only one stick, when will this ATP be produced? When will this rice finish cooking? 1,000 years. So generally, we have something we call basal metabolic rate. There are some people, small thing, they are sick. Small thing, they are weak. Small thing, then they go to the hospital. Your doctor should check you, your body, you, Victor. You are always sick. You come to the hospital. You are always feeling weak. Okay, let's take your blood to the lab. How is your body metabolizing? We want to check your basal metabolic rate. Is it so fast or slow? Somebody has been eating plenty but always feeling losing weight? Is it that you have plenty firewood? That the little food you eat, it metabolizes and out of your body. So basal metabolic rate. Yes. So the higher the hormone, the higher the rate of metabolism. Okay. And if we cook more food, the cells will be happy. They will grow. So poor growth. But if less, so when your thyroid hormone goes low, you get delayed development. Sometimes your brain will be in trouble. They are not receiving enough ATP, glucose. So you begin to what? Then your intestines to constipation. Yes. The liver is producing what? Bile. Waiting to emulsify fat. But here is the case, your thyroid hormone that will speed up production is slow. So the bile will just be sitting in what? The gallbladder. They will pile up, pile up, pile up, pile up. Then they now start sipping out. They sip out, go under the skin, under your sclera. So patient will be having what? Prolonged. This bile, when it enters into your brain, trouble has come. Okay. Yes. So what do we have to do? When you have this issue, we need to give you what? Synthetic thyroid hormone. We call it levothyroxine. Somebody went to do surgery and this thyroid hormone was taken out. Thyroid gland was taken out. You need this for the rest of your life. So imagine you give birth to your boy. Boy is 5 years old and is going to be on artificial thyroid hormone for the rest of his life. Okay. Yeah. Let's look at what? The reverse. The Graves' disease. We have children who are born with what? A lot of firewood in them. So the least thing, they have excessive thyroid hormone production. And that one will trigger the whole body from head to toe. Weight loss. You are eating, but you are losing weight because once the food crosses the small intestine to your liver, the thyroid hormone will facilitate combustion. Okay. But the other aspect is all this metabolism needs heat. So the skin, inside the skin is hot. Will you still apply heat here? No. You apply cold. So what does the saying say goes? These people with hyperthyroidism, their skin, it likes cold things, but it doesn't like hot things. So you say that it does not tolerate heat. Their skin, or their body does not tolerate, because inside them there is always combustion. Yes. Some of them have tremors, goiter. If you are not careful, they trigger into what? Thyroid storm, severe tachycardia, fever. Okay. So you have to give them medication that will suppress the thyroid production. We call it anti-thyroid medication, like what? PTU, propyltyrosol, okay, or metimazole. Then the beta blockers, which works on the heart rate, because if you don't calm down the heart, it will be running fast. It will get tired. Okay. Yes. And you start seeing arrhythmias. People are born with less growth hormone production. Okay. Growth hormone. Where do we see growth hormone? Who knows? Which part of the pituitary gland produces growth hormone? Is it the anterior?
Pituitary.
Is it posterior or anterior? Anterior or post?
Anterior pituitary.
It's a posterior, yes. The anterior pituitary. Okay. Yes. So the anterior side. If this is the pituitary, this is the anterior. This is the posterior. When you see people with what? Deficiency, this is the anterior side. These cells here, what is happening that they are not producing a lot of hormones? Is there a problem here? Or what? Okay. So when it happens, we give them artificial growth hormones medication to help you to grow, to eat, and all those stuffs. Yes. So people like this, if you have suppression, your growth, your physical growth will be delayed, puberty delayed. So we give them what? These recombinant injections to help the production of growth hormones. Some people, so these guys, sometimes we call them dwarfism. Dwarfism. Okay. Then the opposite is the giant, the Goliath, giantisms, excess growth hormone, especially tumor. If I have an organ and the organ produces 10 mils, and the organ decides that, let me develop a new cell here. This new cell is the same cells of the organ that we have excess here. So plus 5 mils. Okay. So tumor, cancer, tumor, excess production, tumor, excess production. Anytime you see, that's the trick I'm telling those of you who are going to write NCLEX. Anytime you see carcinoma cells, so and so cells, cancer produces all of the body. It will start as something benign. Then as the cells mutate, they will now develop new cells that has the ability to penetrate surrounding tissues and organs. At that stage, we call it, the cells are now called metastatic. Metastatic, yes. So there's going to be more production, more production, more production, more production, more production, more production. Yes. When you give medications that will suppress the cancer cell growth, automatically you are suppressing the production of the hormones or whichever juice down. Okay. So we call it immunosuppressions, suppressants. And those medications, they mostly end with all the zols. Medication with zol. Medication with zol. It means it is suppressing something. That is it. Let's look at hematologic. So hematologic and oncology disorders. Iron deficiency anemia. I love iron. Yes. Victor, where do we get iron from? Which food? Yes. No, Victor is not a woman. Woman, you've given birth to your children. Where do you get iron from?
Breast milk.
breast milk, all these milk products. Yes, iron. Okay. Why low iron develops anemia? You see, in the red blood cell, there is a certain juice. That juice is called hemoglobin. This hemoglobin, we use iron to produce it. That's it. We use iron to produce it. So hemoglobin is iron. Okay. And where can I get this iron from? I need to eat iron products. To get iron for the red blood cells to use, or the bone marrows to use it to produce what? Hemoglobin. Okay. If I don't eat, I have less iron. I have less hemoglobin. Simple. If I eat plenty iron, I have more hemoglobin. HB. So people will be getting what? Or plenty hemoglobin. They will say you have what? Polycythemia. So the hospitals will be telling, go and do blood donation. Go and remove some of your iron out or your hemoglobin out. Okay. Yes. So please try and remove some iron. When you remove your hemoglobin out, new cells and fresh cells come and you stay strong. That is it. So be doing blood donations. Okay. So we see paleness, fatigue, irritability, and tachycardia. Paleness, fatigue, irritability, tachycardia. These are all what? Signs of iron deficiency anemia. Okay. So you see your hemoglobin is low, hematocrit too will be low. Okay. Hematocrit will be low. Then your ferritin, the iron, will be low. So in this case, some people, they tell them, let's take them to the infusion ward. Let's go and give them iron infusion. Or, depending on the severity, let's give them iron supplements to take home and take. Vitamin C. Okay. Then expect dark stools. So you will see that you are taking blood tonic. Then your stools will be black. That is the iron part. More blood cell production and more what? Yes. So coming to a close, let me do these two guys. Let me say bye-bye. Okay. Sickle cell disease. This is an autosomal recessive hemoglobinopathy. Recessive gene. Hemoglobinopathy. When you were taking the iron and the bone marrows were producing the hemoglobin, which environment was the mother? Was the father? This baby is here. Okay. Atmospheric environment. Hemoglobin doesn't like environment where there is more stress. Take notes. I want to show you some secret about sickle cell. Okay. They don't want, when we are producing blood cell, hemoglobin, it doesn't want stress. The bone marrows want a comfortable zone to produce what? Hemoglobin. Okay. Once there is stress, it will produce hemoglobin which has what? Defect, which is abnormal. Okay, yes. And it will also produce red blood cells that is secured. That is it. So 2 troubles, 1 God. The hemoglobin inside this abnormal red blood cell is troubled. It has a problem. If it has a problem, what does hemoglobin do? Hemoglobin looks like H, as the name goes. It has 4 receptive sites for oxygen and gases. So oxygen that you breathe will come and sit. One will sit here, one will sit here, one will sit here, one will sit here. And they have affinity for oxygen. Okay. So we always, when you are doing oxygen saturation, it means that this hemoglobin, how many of this molecule sites is receiving hemoglobin? Okay. It goes like this. So it starts from here and it fills up like this. And when you are desaturating, it goes in the reverse form. Like this. Okay. So before the first oxygen on this side will leave, and it will become like this. Something like this. This is what we call desaturation. You use the saturation probe on the finger. It means this site, bonding site, it has lost oxygen. Okay. So it will be telling you, okay, we check the numbers will be reading on the monitor. 91, 92, 93. It means that one of the molecule has lost. The bonding site has lost. Okay. Now the next one will be lost like this. Then it will be left with 2. This one will be going to, let's say, between 80 to, because we have plenty hemoglobins. Okay. So they work together. So you'll be hovering between 80, 70. The patient will be having this. This one has desaturated. So you hear the health worker saying, patient is desaturating. Desaturating. They go in that anti-clockwise format. Okay, sickle cell. Then, or even normal patients. So this one will desaturate. Okay, when this one desaturates, now you have a hemoglobin with only 1 oxygen here. And once this one goes off 60, this one will automatically drop. So you realize that when a patient is desaturating, I don't know if you have seen patients, you are monitoring a patient and the patient died. You realize that when the oxygen levels get to 60 and 50, within a short time, it will go back, 0 or 10. Yes, that is the speed. Once this third guy leaves the site, this one will follow. And the patient will desaturate. And I tell you, this is only 1 molecule of hemoglobin. So imagine in the body, we have plenty hemoglobins and plenty red blood cells, and they are all desaturating in that speed. So if you look at the oxygen dissociative curve, it looks like this. When you are building, it builds like this. So when we want to, somebody will give oxygen. Okay, let's give the patient oxygen. You give oxygen. So the oxygen will bind. 1. It starts from here. the more we get more oxygen on the hemoglobin molecule, the more this curve, it started from 0, then it goes a little above, let's say 5. That's the oxygen saturation. It goes, then it goes. It will reach to a time that it will plateau. So when it plateaus, we say that this patient, depending on the condition of the patient, what is the plateau level of COPD patient? Who knows?
Okay,
The normal oxygen saturation of a 88 to
88
what?
to 90, 93.
Okay.
I think
88
90.
to 9. Yes. So COPD patients can survive within this range.
92. 92.
Okay.
88,
92. Some say 92, 93. Okay. So they survive within this range. When they get to this level, it means their curve has gotten to the plateau stage. Don't force it to go up. Otherwise, you blow off the hypoxic drive. The brain will not be receptive to CO2 again. So they can't breathe. You knock it off. So you are giving oxygen, but the patient will die. That is it. So we are saying that be careful when you are giving patients oxygen. Oxygen is a medication.
Sir,
Okay,
please, I
so
didn't hear
be careful.
the normal range. Please, if you can come back again.
For what?
And
So
COPD.
The
88
COPD.
to 90.
88. A normal human being is, I think, 95 to 99. COPD. COPD is 82 to 89. Okay, yeah. And when they are dropping, so you connected oxygen to the patient before your hemoglobin was empty, you gave 1. So the curve will be like this. That little you gave, it has climbed to here. Continue giving high flow oxygen, running under humidified liquid, it will come here. Another one will bind, so it will climb up here. Okay, then this one will bind, then it will climb up. Then when you give more, then plateau. So once it reaches your plateau, it's okay. Keep it there. So patients will come to the hospital when you hear this is the hot, this is the basic, or this is the baseline of this patient. We have some human beings walking on earth. You see them with oxygen in town, oxygen at their back. Go and check the oxygen cylinder. There is a flow meter attached to it. The flow meter is always at 1 unit, okay, or 2 units. What is the unit for oxygen? Flow. I mean, somebody will be 4 liters, 5 liters. That is their baseline. So they are surviving on that baseline. We have people who have all these atelectasis. People have been smoking weed and smoking cigarette and all those stuffs. They have caused majority of their alveoli to damage. Okay. So for them, 99% is not their baseline. And oxygen, I mean, so sometimes they give them 4 liters, 2 liters. You'll be on it till you die. That is your baseline. So they have reached. So my baseline is different from Ayariga's baseline. And Ayariga's baseline is different from Nicola's baseline. But when we take our curve is like this. So I can be smoking cigarettes for 10 packs a day. With time, give me like 5, 10 years. I will plateau here. I'll plateau here. because I wouldn't have plenty alveoli to push me to this level. So 80, 81, 82, 83. Okay, that is where I am able to survive. That is it. That is, and when you are desaturating too, it goes like this. That is how hemoglobin does. So this guy with sickle cell, who has an abnormal hemoglobin and also has an abnormal red blood cell. And everybody who's who is not sickle cell, red blood cell lasts 120 days to die. This guy will go like 60 to 70 days and it will die. When it dies, hemoglobin will be released into the blood. And the dead cell will go to the spleen. Okay. So we put the spleen, sickle cell patients, their spleen is always working. The least thing, they get splenomegaly. We need blood cells. Their liver is always working. Their bone marrows are always working. They need cells, folic acid. So like the pregnant woman who is in the first trimester, who is carrying a baby, and she needs folic acid so that the baby can get plenty cells. We are not God. We can't create cells for this sickle cell guy. The only thing we can give him is folic acid, because folic acid helps the body to produce more cells. So this folic acid will go to the bone marrow. We will get more red blood cells. We will go to the liver. We will get more cells. We will give to the spleen. You get more cells. That is it. We don't want their blood to be thick. The plasma part of their blood, we don't want to go low. We don't want them to be dehydrated. So, because once the plasma concentration reduces, the blood is going to be left with the red blood cells, the white blood cell. The blood will be thick. It cannot flow. When blood is thick and it cannot flow, what happens to the sickle cell red blood cells? When they get to these tiny capillaries, like this sickle cell, it is what? It is malleable, that it can change its structure, nature. So it passes through small holes. But because this is sickle cell, it will come and get locked here. So another one will come and lock on it. Another one will come and lock. This cell that it is going to deliver the blood to will start starving for oxygen and glucose. When that happens, impulses are sent to what? The bone marrow. The bone marrow, it is your duty to produce blood cells. Okay, so produce. So there's more pressure on the bone marrows. So you see sickle cell patients getting what? Joint pains. Joint pains because of the pressure. What can we do to remove this occlusion, vaso-occlusive crisis? Sometimes it is not the capillary problem, but it is what? The cold weather has closed the blood vessel. So you apply hot compress to dilate the blood vessels. Okay. So IV fluid, you put it in what? A fluid warmer to warm the IV fluid before it gets to the patient. This patient has come to your theater you are doing orthopedic surgery. You applied what? You applied this thing. How do we call it? What's the name of this? Oh, these orthopedic guys, they apply it on the thigh. So when you apply it here, you are preventing blood flow. What happens to the cells here? Okay. So all these things are what? Issues of a sickle cell patient. Yeah.
So are you talking
When
of
they
ice
have
pack?
infection, not ice pack, we call it, I've forgotten the name, but you don't give ice packs to sickle cell patients.
Please, is
They
it
will-
tourniquet? Is it tourniquet?
Tourniquet. Yes, tourniquet. So you time the tourniquet. When was it applied? You time it. Okay. Yeah. So oxygen in control, hydration, infection prevention, then they immunize. Those in abroad, winter will come, immunize. Infection prevention is very key. So your vaccinations and your immunizations, give it to the baby. Right. So let's end here. Then tomorrow we continue with what? The others, the blood. So we do the leukemias and all those stuffs. Okay. Thank you very much, guys. We meet again. Any questions so far? Any
Sir,
question?
please, I have a question.
Come again.
Sir, please, I have a
Hello, sir.
question.
Ask me.
I equally have a question.
Okay. Shoot.
Okay. It's gift.
No.
When you were, can I ask my question, sir?
I didn't hear you. Please, who heard her?
I said, please, can I ask my question?
Yes. Ask your question. He said shoot. So kindly ask your
Please
question.
go
Yeah.
ahead. Go ahead and
I'm
ask your question.
listening.
Okay. When you were teaching about DKA, you mentioned you said that yes, that we have to use fluid. Then you asked a question. You asked if you want to give insulin and the potassium level is too close, would you give the insulin? I think you asked David Nicholas. So, but the answer, after he responded, I don't know, but I don't think you gave the answer. Okay, yeah, he said that we have to make do with the fluids until when the insulin rises or something, that we don't have to give insulin. So I want to know the right thing to do in that situation, please. Thank you.
When you give insulin and insulin gets to the bloodstream, they push away potassium and they push away glucose. Okay. Remember, it is this potassium that is helping the cell membranes of the heart to work very well. The cardiac membranes to work very well. Okay. So if you go and potassium is low, let's say 2.0, already the heart is struggling because of the low production of or low concentration of potassium in the blood. So will you go and still give insulin and push further down that your potassium will be now 1.0, you will stop the heart, because the physiology says potassium pumps the heart. P for Paul. Potassium pump the heart. Yes, it helps the cardiac membranes to work very well. Okay. So when you go and potassium is low, treat the potassium first before you give insulin. Please, do you understand? That's why Nicola said you give KCL, KCL IV. Yeah. So this is very low. This is critical. Yes, Dave. Shoot.
Hello, sir. My question has to do with the sickle cell patient. Along the line, towards the ending part of it, you made mention that we shouldn't apply tourniquet for a long time. Considering our aspect of the world, even though let me deviate more from the ankles, terrain. A patient like that, the veins sometimes will cause some of us to come and try before we could get it. So I want to find out which the number of minutes that we are supposed to tie the tourniquet before we assess the vein. Or you can understand the person is in severe pain. And without passing the line, it's difficult for you to administer some of the medications. So I want to find out if there is a remedy for that.
Okay, the tourniquet I was talking about is the one used in
this one, it requires
orthopedics.
microscopic eyes.
Have you seen the orthopedic tourniquet before? This one.
No, sir. But where we are, we use sometimes we use this thing. We are improvising. We are in a country that they always tell us to improvise. So sometimes we can tear the tip of the glass, around to tie the child hand. Yes. We are in the remote area of Ghana. So sometimes we have to tear the ending part of the glove, use it to tie. Then sometimes maybe you can even use the normal tourniquet. Then you stretch it before you pass a line.
David, you
get it.
King David.
Yes.
David, you are getting two concepts. The tourniquet is talking about is orthopedic tourniquet and not our usual tourniquet that we use whilst we are setting an IV line. But when you want to do amputations in the theater, that is what he's just displaying on. The orthopedic tourniquet is different from the usual IV lines, sir.
This one's.
Let me limit myself, sir.
A tourniquet, yeah. Yeah.
Let me limit myself.
Okay. Any other question? Any other question? Okay.
So
if
please,
no question,
I want to find out, is there a case where insulin will be produced, all right, but it cannot work? Is that what we term as insulin insensitivity?
yes. So that one is type 2 diabetics. Okay. Type 2 diabetes, we mostly don't see them in pediatrics because that one, as you age, you begin to get so many issues that it will desensitize your insulin receptors. Okay. So your pancreas is intact. The beta cells are producing the insulin. And when it gets to your blood, that's binding site is destroyed or malfunctioned, or something is already blocking it, stopping the binding. Okay. That's why we take in all these metformins and those stuffs. Those ones help insulin. it increases the affinity of the binding site to the insulin, so that the insulin will bind to the site and let glucose go out. You understand? But we normally don't see them in pediatrics.
Okay.
Pediatrics mostly have type 1. That is why I didn't touch on that.
Okay. Thank you.
Okay. So guys, let me leave you. Okay.
Thank you so much. God bless you.
Okay.
Sir, thank you very much. God bless you. Have a nice day, sir. Greetings to the family.
Okay. Thank you. Bye-bye.
Thank you so much, sir.
God bless.